Okay, can see a number of participants joining, which is great. Welcome everybody to this week's Melbourne Children's Global Health Forum, which is in fact a MCGH Peter Doherty Institute Global Health Seminar Series. It's a great pleasure to welcome you all to this seminar today. So this is part of a quarterly seminar series, and we have three excellent speakers today, and we're discussing azithromycin. The title of our session is Murdoch and Beyond, One Drug to Rule Them All. So I'd like to begin by acknowledging the traditional owners of the land on which you and I are meeting, and acknowledge and pay our respects to the elders past, present and emerging. So azithromycin is a fascinating drug that has broad clinical and, it seems, public health applications. My own experience with azithromycin has been in the Solomon Islands for trachoma elimination, and soon to be also yaws elimination. And it's very interesting, this experience with trachoma has, mass drug administration has raised the possibility of its more broader effects on childhood morbidity and mortality, and also applications to other infections, including malaria, and there's a long history of azithromycin and malaria. So we're very fortunate today to have three fantastic speakers, and it strikes me actually that it's quite amazing we have the level of expertise across multiple domains related to azithromycin and its public health benefits around the precinct. So first we're going to hear from John Hart, who's going to talk to us about the Murdoch trial and his involvement in it, particularly through his experience in Malawi. And then Fiona Russell on prevention of perinatal infections in Fiji. And then Stephen Rogerson talking about azithromycin in pregnant women in Papua New Guinea. So really great session today. So please feel free to put questions in the Q&A box. Our plan is to have the three speakers speak one after each other, and then have the last 10 minutes for questions and discussion. I think that probably works best in the webinar arrangements. As ever, I'd like to thank the organisers, particularly Josh Osowicki. Many of you who know Josh won't be surprised that he came up with the title, excellent title for today. Also Anna Doe, Nicole Romero, Ricardo Atadi and Layla Larson. So I'm going to kick things off now and introduce John Hart. So John is a clinician researcher with a background in tropical medicine and international health. He's currently working at the Melbourne School of Population and Global Health, and also does some work at the MCRI as well. His current focus is on verbal autopsy and cause of death data in PNG. But he has quite significant experience in clinical trials in sub-Saharan Africa and Asia with Oxford University and the London School, and most recently on the Murdoch trial in Malawi. And so it's a great pleasure to introduce John, who's going to speak to us about the Murdoch trial. Over to you, John.
Thank you very much, Andrew. I'll just try and share my screen first of all. Okay, hello everyone. So as Andrew mentioned, I worked on the Murdoch trial. I was based in Malawi. So I'm going to discuss the Murdoch trial overall, but there will be a few additional details about the Malawi site where I was based. So firstly, the acronym. So Murdoch it actually comes from the French for oral macrolides for reducing deaths with an eye on resistance, or more simply, some letters from mortality reduction after oral azithromycin. Of course, it's memorable because of the connotations to Middle Earth, and I also love the name that Josh came up with, One Drug to Rule Them All, for this talk. And that reminded me, I don't know if people here would know Adam Kay and Suman Biswas, the amateur transplants who sang a song about a drug to treat everything called paracetamol, oxyfruzi, bendroneomycin. So it certainly reminded me of that. Anyway, on to Murdoch. So our study question was, is child mortality reduced in communities randomized to azithromycin versus those randomized to placebo? So it's a single multi-site trial conducted in Niger, Malawi, and Tanzania. It had 80% power to detect a 10% mortality reduction in children aged 1 to 59 months at those 3 sites combined. So I'm just emphasizing there that we're going to look at the data in more detail, breakdown by site and by other characteristics to try and look at potential mechanisms of effect and develop hypotheses towards that, but we're really not powered for those additional analyses. So the study was a collaboration between 3 universities. UCSF were coordinating the trial in Niger, Johns Hopkins in Tanzania, and LSHTM in Malawi. So in Malawi, we had 334 clusters. So that was a cohort of about 90,000 children. The trial was somewhat smaller in Tanzania and larger in Niger, and a total of about 320,000 person years of follow-up in the study overall. So the study was organized with the study clusters in Malawi were health surveillance assistant areas. So the HSAs are similar to community health workers in other settings. So they'll have a population of about 1 to 2,000 individuals under them. And the trial was organized to do household visits to all the households in the study area. And depending on the randomization to azithromycin or placebo, to offer all children aged 1 to 59 months at each household the study drug. So in Malawi, the HSAs, the Ministry of Health employees, they administered the drug, and we had trained field workers who would update the census and record the treatment data. And we had about 20 of those teams working at any one time, and it would take about 3 months to complete a round of field work. Then there'd be additional activities. We were following up deaths with verbal autopsy to try and understand cause of death, and I'll talk about that a little bit more later on. And then there'd be a short down period before the next round of fieldwork for another 3 months. Throughout the study area, there were 30 clusters that were randomized for more intensive follow-up. So we would take anthropometry measurements and various clinical samples. And this was to assess, firstly, for the development of macrolide resistance. And also, if we were going to identify a reduction in child mortality, could we look at pathogen prevalence to give us some indication of what the mechanism of effect may be? The study site in Malawi was Mangochi district. So the map on the left is the country of Malawi, and you can see the lake in blue, and at the southern end of Lake Malawi is Mangochi district, highlighted in red. The map on the right has a pin for each of our 334 study clusters. You'll see that the 5 colours represent 5 administrative zones for health in Mangochi district. So for administrative reasons, we organised our fieldwork by these 5 administrative zones. And subsequently now we're doing some additional analyses of the heterogeneity of effect of azithromycin on child mortality by these defined geographical areas. And also we collected some additional data at the Malawi site to look at heterogeneity of effect by underlying child mortality, but also water and sanitation, hygiene indicators, socioeconomic indicators, and some geographical and distance variables as well. So I'm not going to go into those in detail in this talk. I'm going to stick to the main trial results in the interests of time. So a few quick photographs. This is from one of our study communities looking out at Lake Malawi. Some of our field coordinators there taking a break by the lake. And here, this was one of our study days. So these are our census enumerators setting up tablet devices. So all data were collected on an Android device with a custom-made app and uploaded to a cloud server. So we used height sticks to estimate a dose of 20 milligrams per kilogram of azithromycin, or the equivalent volume of placebo syrup. So you can see these girls will be offered 10 mils of the MDA. And for smaller children, they were weighed and given an exact dose based on their weight. This is so a baby being treated, and I think the treatment's fairly sweet and was generally taken well, which of course is easier if they're coming back asking for more rather than getting refusals. So quickly onto the results. So The main finding of Murdoch was that at those 3 sites combined, there was a 14% lower mortality in children aged 1 to 59 months in those allocated to azithromycin versus those allocated to placebo. So if we now start looking at those data in more detail, so the chart here shows on the y-axis the percentage lower mortality in the azithromycin arm, and on the x-axis we've got the overall result on the left, and then the different country sites. You can see the bulk of the evidence there coming from the Niger site, that relatively high effect estimate of 18% with quite high confidence intervals and quite tight confidence intervals, and the relatively low effect estimates in Malawi and Tanzania with a wider confidence intervals there overlapping 0. Breaking those data down now by age group. So we've got the same y-axis here, the percentage lower mortality with azithromycin, and now on the x-axis we've got the age group, so 1 to 5 months, 6 to 11 months, and then the older age groups. So you can see the overall effect estimate in the youngest age group, the 1 to 5 months, is around 25%, and that's relatively consistent across the study sites. Whereas at the Niger site, there's a similar effect estimate in all infants, and still a relatively high estimate with quite tight confidence intervals in the older age groups as well, whereas no evidence really of any effect in older age groups at the other sites. Now looking at the efficacy of this intervention over time. So the same y-axis, but now intercensal period on the x-axis. So the first intercensal period is between the baseline census and first treatment and the 6-month follow-up, and so on over the 4 treatment rounds of the study. So you can see, if anything, the trend is towards an increasing effect over the course of the study, and this is relatively consistent across the study sites. So of course, a major concern with any antibiotic MDA is the potential for the development of antibiotic resistance, and the implications of that may be reduced efficacy of the intervention with repeated MDA, as well as potential clinical effects in the study area. So it's interesting to see that, if anything, over in Murdoch there appeared to be an increasing effect over time. And a hypothesis for that, if that is shown in additional studies with further data, could be that with repeated administration, we're further suppressing pathogen prevalence in those communities. And a final chart. So at the Niger site, they continued the Murdoch trial for an additional year, for an additional 2 rounds of treatment, but with the change that the placebo communities would now receive azithromycin. So this chart now has mortality rate on the y-axis, and again intercensal period on the x-axis. So the blue dots are the placebo communities and red dots for azithromycin. So the blue dots here, this is mortality rate in placebo communities during Murdoch. And then when those communities received azithromycin, you can see the mortality rate falls to similar to the azithromycin community. So I think with the bulk of the evidence from Murdoch coming from the Niger site, this is some interesting additional data, some evidence against this being due to bias, for example, in the selection of study clusters at the Niger site. So of course, when we're thinking about what the mechanism of effect may be, it'd be great to have good data on causes of death in the study area. It's very difficult, as you'd know, in low-income settings to get data on cause of death. What was done in the Murdoch study was the use of verbal autopsy, so structured interviews with relatives of the deceased that can then be analysed to infer most likely cause of death. And the indications were from the Malawi site of lower pneumonia and diarrhea or HIV mortality in the azithromycin communities, and in Niger of lower malaria, dysentery, meningitis and pneumonia mortality in the azithromycin treated communities. So you can see there several infectious causes that would feasibly be amenable to a broad spectrum antibiotic, and one that we know has antimalarial properties as well. So I mentioned the morbidity data we collected. We're still analysing a lot of these data, but some that are available and I can discuss. Regarding malaria parasitemia, there was no strong evidence of a difference between arms in Malawi or Tanzania, although the indications were of lower prevalence of malaria parasitemia at the Niger site. So these samples were collected 6 months after the previous MDA. So this is indicating a sustained reduction in malaria parasitemia over 6 months. So we could hypothesize that that may be related to the background malaria prevalence. So we know background prevalence at the Niger site was around 10%, was in Tanzania it was around 15 to 20%, and in Malawi it was over 30%. So if azithromycin is having an effect on malaria prevalence and the transmission of malaria, it may be that in higher transmission areas that cannot be a sustained effect over a period of 6 months. Regarding macrolide resistance, the evidence from Malawi and Niger indicated an increase in pneumococcal resistance over the course of the study in both pneumococci and in intestinal flora from the Niger site. That wasn't repeated with the Tanzania data, although they had relatively low isolation rates of pneumococcus at that site. So to summarize, Murdoch provides the best evidence to date and does indicate a beneficial effect of azithromycin MDA on child mortality. It appears that this effect may be greater in higher mortality areas and in infants, although we don't have strong evidence for that at this stage. I've added a note here of an additional sub-study, further analysis of the Murdoch data. And this is that if Murdoch had targeted only those youngest age groups where there's the greatest effect, so if Murdoch had targeted just 1 to 5 month olds, this would have reduced the absolute number of deaths averted 6-fold. And just targeting infants would have reduced the deaths averted 2.5-fold. So I think this is interesting to consider if this is being considered as an intervention regarding cost and cost effectiveness. If it's going to be implemented as Murdoch was with house-to-house visits, there's very little additional cost for treating additional children who are present in the household. But of course, that's one consideration. Another important consideration is macrolide resistance. And I've just said the evidence from Murdoch, certainly from Niger and Malawi, is that macrolide resistance does develop with biannual treatment of children aged 1 to 59 months. And that is similar to previous data from trachoma studies, where it's usually been whole community treatment with azithromycin MDA, but that macrolide resistance does develop. And of course, with a greater proportion of the population being treating older children as well, it may be that there are higher levels of macrolide resistance. Data from the trachoma world does indicate that macrolide resistance generally reduces back to similar to baseline levels after 1 to 2 years. So the future direction of this as an intervention, we know the WHO were considering guidelines for azithromycin MDA for reducing child mortality. And they were considering particularly that this should be targeted to 1 to 11 month olds, but that there should be ongoing monitoring and research regarding both the effect on mortality as well as on macrolide resistance. And they were considering specifying that there should be ongoing attempts to improve other proven child mortality interventions. So things such as improving vaccination coverage in the intervention area. So at this stage, we believe the WHO are probably most likely waiting for more data before they commit to guidelines for this as an intervention. And we know there are trials underway. There are several in West Africa as well as other countries and in the Pacific region regarding the effects of azithromycin MDA on child mortality, on infant mortality, on maternal and neonatal effects and other morbidity indicators as well. And of course, the results of those studies will influence future implementation guidelines as well as the future direction of research, because I think, as I've outlined, there are a lot of questions still to be answered in this area. So thank you very much. I will stop there, and I very much look forward to the other 2 talks and discussing a bit later, discussing further. And of course, a big thank you to our collaborators and all of our participants. Thank you very much.
Thank you, John. Outstanding presentation on an amazing study, and also perfectly within your 15 minutes. So I also very much appreciate that. There's been a few questions for you in the chat. So if you would like to, feel free to respond to those. But we'll save up other questions just in the interest of time for the last 10 minutes. So now it gives me great pleasure to introduce Professor Fiona Russell, a paediatrician who is Director of Child and Adolescent Health PhD program in the Department of Paediatrics, and is a group leader of the Asia Pacific Health Group here at MCRI. Had the pleasure of working with Fiona for a long time. Very passionate about her research interests, which is evidence-based decision-making around critical child health issues for children in low-income countries, especially related to vaccine-preventable diseases. And she's currently leading a clinical trial of azithromycin called Bula Bula Mape, and we're going to hear about this clinical trial in Fiji from her now. So over to you, Fiona. Thank you.
Thank you, Steri, and thank you for the invitation. And yes, as Steri said, I'm going to be talking about Bula Bula Mape, which in Fijian is wellness in mother and baby. And here's our wonderful, most of our study team in Fiji in the photo. So maternal infant infections are a huge issue, particularly in low and middle income countries and globally. So in infants, about 21% of all the almost 3 million neonatal deaths are due to infections worldwide, and the bulk of these occur in low and middle income countries. And about half of all under 5 deaths, childhood deaths, are due to infections as well. For neonatal sepsis, there's generally sort of 2 ways infants sort of get infection. There's the early onset and there's the late onset. For early onset, the definition of that varies a little bit, but generally it's up to about 3 days post delivery, and that's usually by vertical transmission of Group B Streptococcus or E. coli. And then there's late onset neonatal sepsis, which is after 72 hours of age and in infants up to less than 3 months of age, and this can be by horizontal transmission or late onset vertical transmission, and also outbreaks in neonatal nurseries. And there's different pathogens in low and middle income countries compared to high income countries, and certainly a much higher mortality in low and middle income countries. For mothers, postpartum infection is a major cause of maternal mortality worldwide. There's about 5 million cases of pregnancy-related infection every year, and about 75,000 maternal deaths due to perinatal infections. Now, a lot of the Murdoch, as John has said previously, there was an age difference in an effect, and particularly the younger children, infants 1 to 5 months of age, seem to have a higher effect. And that's thought primarily due to probably the impact on Staph aureus and also Streptococcus pneumoniae. Now, when it comes to Streptococcus pneumoniae and the distribution of it by age, we did a review a number of years ago for WHO and looked at the age distribution in the first 5 years of life, a global review. And these are the graphs that are shown here. The black dots are the observed data, and the red is the model data looking at pneumococcal meningitis and the age distribution. So the x-axis is age in months, and then this is the prevalence on the y-axis, and we did it by different regions, so Afro, the Americas, Southeast Asia, Europe, and WIPRO. Didn't have a lot of data from everywhere, and you can see here in the neonatal period, which is this open circle, we didn't really know where to place that dot. And the reason for that is often neonates are excluded from surveillance, they don't get the samples taken, or they die at home. So really the contribution of pneumococcus in the neonatal period is sort of unknown, especially in low and middle income countries. What we did in Fiji was to explore this further, to look at the association between vaginal delivery and pneumococcal carriage, because for pneumococcal invasive disease, carriage is a prerequisite to invasive disease. So we had 5 to 8 week old infants, which are about 2,000 of them. Nearly 90% had a vaginal delivery. The other 13% were delivered by cesareans, and we found that their Carriage in those born by vaginal delivery was significantly higher than those born by caesarean delivery, and that we found a positive association between vaginal delivery and carriage. And so this is, obviously not causation, but it's the first study to show an association between, and there might be other reasons, of course, for that, but that's why one of the justifications also while we're doing this trial. Now, in terms of preventing neonatal infections, there's a number of ways to do that. So antenatally, women get vaccinated with tetanus toxoid in low and middle income countries to prevent neonatal tetanus. There's Group B screening, Group B strep screening and prophylaxis, and ideally, it would be best to vaccinate, but there's no vaccine yet, and that's quite a number of years off yet. And also women get STI screening and treatment, so syphilis, to prevent congenital syphilis in infants. There's also intrapartum things to do. So in some high income countries, they recommend prophylactic antibiotics in labour for women who are Group B strep positive. And in the US, this is found to reduce early onset Group B strep by about 70%. And so a study looking at 16 years of data from the US found about 70,000 cases of early onset Group B strep neonatal sepsis were prevented by screening women in pregnancy and then giving prophylactic penicillin during labour. It also can be based on treatment on chorioamnionitis symptoms in women as they're in labour. But if this misses about 50% of neonatal sepsis cases. And of course, it's so important to have cord care and improve intrapartum hygiene, and sort of additionally, the important role of breastfeeding kangaroo mother care. So skin to skin care has been shown to reduce hospital-acquired infection in 50% in low and middle income countries. So skin and soft tissue infections are a common cause of sepsis for mothers and babies, and commonly caused by Staph aureus and Group A strep. And these are some examples here, and they provide a portal of entry to invasive disease. And so Andrew Steer and his group have been leading this work in our region and globally. In Patogo, a systematic review found that more than 160 million children at any one time had a prevalent infection. And in Pacific countries have the highest burden, with 30% in Oceania versus 7% in Africa and Asia. And in Patogo, so skin infection is key for high rates of invasive disease and high case fatality rates. The Murdoch study, John has just nicely summarised, and the thing that I just want to highlight here is the, the 1 to 5 month old infants where it had the greatest effect, a 25% reduction in mortality in this age group. Now in the Gambia, there's a randomised control trial of about 800 women, very similar to where we got our idea for our Bulla Bulla study, where they randomised women to azithromycin or placebo as they were in labour. And what they found was that they found a reduction in Group B strep, Staph aureus and pneumococcal carriage. So on the right-hand side, I hope you can see, it's a bit fuzzy, but the top left-hand graphic is nasopharyngeal carriage in infants. This one that I'm circling is nasopharyngeal carriage in mothers, and this is in breast milk. And so the red is placebo and the black is their treatment group. So there's azithromycin group. They looked at pneumococcus, Staph aureus and Group B strep, and then pooled all the bacteria. And this is up until 2 months of age, and you can see that there were differences, significant differences, particularly early on in strep pneumo and Staph aureus in the babies and the mothers, and also for Staph aureus and Group B strep in the breast milk. And what they also found was a reduction in maternal and infant infection, so a 60% decrease in maternal infection, a 71% decrease in maternal mastitis, and about a halving of infant skin infections up to 2 months post-delivery. So another study in the US looked at the prevention of maternal postpartum infections. This is a few years ago. They did a clinical trial, randomised women undergoing non-elective caesarean section to azithromycin or placebo in addition to their standard wound protection antibiotic prophylaxis. And using a composite infection outcome, they found a reduction in all infections that they looked at, and particularly when they looked at individual outcomes, they found a decreased maternal endometritis and decrease in wound infection. And then Steri, as he had sort of mentioned, in his group have been doing MDA, so mass drug administration of azithromycin and ivermectin to prevent trachoma and other tropical infections, yaws, etc., in the Pacific, in the Solomon Islands. And so they found 3 years after this intervention that there was a reduction of up to 60%, 3 years compared to baseline. And these are in older people, not neonates. So in Fiji, Fiji is an upper middle income country, about 30% live in poverty, relatively low infant mortality and low maternal mortality rates. Most deliveries are in hospital, and women have good access to care by and large, and antibiotic use by and large is regulated, and there's low azithromycin AMR rates. Very high infection rates, though, in Fiji, about 16% of all neonatal deaths, about 22% of under 5 deaths, and 6% of all infants get a skin or soft tissue infection by 6 months of age. And most of these are due to Staph aureus and Group A strep, and this is Steri's work again. And impetigo is a key for high rates of invasive disease, with very high rates there and high case fatality rates. Also, others, John Kaldor and his colleagues have looked at and screened women in antenatal care and found high rates of sexually transmitted infections. So chlamydia, this is in asymptomatic women. So just screening women in pregnancy, about 33% have chlamydia and 9% have gonorrhea. So looking at hospital infections for infants in Fiji, the rates in infants, so under 1 year of age, is about 30 per 1,000 live births. In under 3 months of age, it's 10 per 1,000 live births. And we've been doing invasive disease surveillance for a number of years in Fiji, and very high rates of very good, rates of lumbar puncture and blood culture practice, and we've found that meningitis rates in infants under 2 months of age is about 10 times higher than that in the UK. And so we've also found, we looked at the data from the laboratory and looked at women who had been had a swab taken if they had symptoms in pregnancy, and found that 10% had Group B strep, and this is by routine culture, so not sort of PCR. And we found for young infants, 25%, otherwise healthy infants, had 25% had Staph aureus carriage, and 37% had pneumococcal carriage. And then the older infants, about 45% had pneumococcal carriage in healthy, otherwise healthy children. And so this is a randomized controlled trial, blinded study, phase 3 in Fiji, where we're randomizing 2,110 mothers to azithromycin in labour or placebo. Otherwise, to be eligible, they're adults and otherwise sort of healthy. The women are randomised to getting 2 grams of oral azithromycin or placebo in labour, and we commenced about a year ago, and so far we've randomised almost 700 women. We were stopped for 4 months because of COVID, but have restarted again. So the outcomes, the first primary outcome is infant skin and soft tissue infection. It's cumulative incidence up to 3 months of age. And we've got a number of secondary outcomes up to 6 months of age of infections in mother and baby, antibiotic use, safety, and also looking at potential adverse effects on the infant and disruption to the microbiome, such as adiposity, allergy, and wheeze. We've also got a sub-study, so just under half of the women and babies will be getting various microbiological outcomes, so looking at carriage for 5 different bacteria, the commonest that cause maternal and infant infections. We're also looking at antimicrobial resistance. We'll be looking at impetigo and taking swabs and looking at Staph aureus and Group A strep and AMR, and also looking at maternal STIs with Deborah Williamson from the Doherty. And in an even smaller subset, we'll be looking at microbiome in the infant gut and maternal rectal vaginal samples to see whether, particularly in the infant, to see whether any disruption in the microbiome early on in the neonatal period predicts either AMR or adverse vaccine responses. So I won't go through all the details of this, but we're basically recruiting women antenatally. We're rechecking eligibility and delivery. We've got a number of time points where they're followed up, and our primary outcome is at 3 months of age. So add-on studies, we hope, if we have funding, to look at resistome for all the things that John mentioned before, looking at whether, the effect on antimicrobial resistance, ideally looking at vaccine responses, a pharmacokinetic study to understand, is it coming through breast milk, the route of transmission, and more how it's working. And also ideally, if we get funding to follow up the babies until 2 years of age. And very importantly, we aim to look at a risk factor approach to prophylaxis. So if azithromycin is effective, but there are potentially some adverse and untoward microbiome and AMR effects, which pregnant women should we be actually targeting rather than doing sort of a mass treatment or mass prevention? And so we're planning on looking at the number needed to treat to prevent infections versus the number needed to treat to develop any of these adverse events. We're doing a study looking at the predictors of neonatal sepsis, and then putting all that information together, develop a neonatal sepsis risk calculator so we can be much more strategic and targeted about who we actually treat, which mothers we actually treat. So as John sort of alluded to, in terms of there's many other studies being done now, a massive amount actually, and their outcomes are either neonatal death or stillbirths. Stillbirths, there's about 3 million stillbirths globally, with about 97% of those occurring in low and middle income countries. And so there's huge trials being done, either individually randomized or cluster trials in many countries. And there's really probably about 150,000 pregnant women and their babies being randomized and studies underway at the moment. So I'd just like to thank very much all the team, all the people involved, and over to you, Steri. Thank you.
Thank you, Fiona. It's really is a remarkable study, and terrific to have it back recruiting now after the break with COVID. So congratulations to you and the team. So I'd now like to introduce Stephen Rogerson. And after Stephen, we'll have time for questions. So Stephen's a professor of medicine in the Department of Medicine at the University of Melbourne. He co-leads with Kanta the Global Health Initiative at the Doherty, and he has many interests, including pathogenesis of malaria in pregnant women and young children, and prevention of malaria in pregnancy, with long established research in Malawi and PNG. So we're going to hear from Stephen today about azithromycin in pregnant women in PNG. So over to you, Stephen. Thank you.
Thanks very much, Andrew, and thanks to Josh for organising this seminar. So the study we did in New Guinea was around prevention of malaria in pregnancy with what's called intermittent preventive treatment. There's about 100 million women globally who are at risk of malaria whilst pregnant each year. And it's worse in the first pregnancy. So for the last 20 or so years, intermittent preventive treatment in pregnancy with sulfadoxine pyrimethamine has been recommended by the World Health Organization in Africa, but there's been a problem with increasing parasite resistance to SP. So IPTP means giving a regular treatment dose of anti-malarial at pre-specified times, regardless of presence of symptoms of infection, usually at monthly intervals through antenatal clinics. So there's been interest in alternatives to SP, and these include dihydroartemisinin and piperacin, of which there's some large studies going on, mefloquine, which proved to be a bit better for malaria, but no better for pregnancy outcomes, and SP and azithromycin, which we did a study on in New Guinea, following on from a couple of earlier studies done in Africa. The study was done in the north coast region of Papua New Guinea, in and around Madang. It was a randomised controlled trial with 2,792 pregnant women enrolled in the second trimester of pregnancy. They were all given bed nets, and they were randomised either to get a clearing dose of SP plus chloroquine, or to get SP plus azithromycin, 1 gram twice a day for 2 days, so a high dose, 4 grams total, and that was repeated at 4 weekly intervals, whereas the SP chloroquine mothers just received placebo at further visits. Our primary outcome of interest was low birth weight, less than 2,500 grams, and we had about 80% power to detect a 25% reduction in low birth weight from 16% to 12%. This is an area with pretty high malaria transmission, and we did pilot work suggesting that 20 to 25% of pregnant mothers were had malaria when they first attended antenatal clinic, but in fact malaria fell in between times, as you'll see in a minute. But we did find a positive benefit, and this is showing firstly the unadjusted and adjusted low birth weight, and then the mean birth weights for the study population. And you can see that in the adjusted low birth weight analysis gave us a 27% reduction in low birth weight. For the mean birth weights, there's not a very dramatic difference in actual birth weights, around about 50 grams, but I'll come back to that in a moment. But overall, in terms of our primary outcome, we had an absolute risk reduction of 4.4%, number needed to treat of 22, that is to prevent one low birth weight, treat 22 women. And interestingly, as a secondary outcome, we looked at preterm birth, and there was a 38% reduction in preterm birth compared to our control arm. This is the a kernel density plot of the birth weights of all the participants, with the SP chloroquine in the blue dotted line and the azithromycin in the red line. And the striking thing about this was the kind of deficiency of the number of births in the lower ranges in the azithromycin plus SP arm, and the kind of heaping up around the median of the birth weight curve. Whereas when you get to the higher parts of the curve, there was no real difference between the two arms. So is this due to malaria? Well, we did see a significant benefit against malaria, with about a 40% reduction in detection of malaria, either by peripheral blood microscopy or placental microscopy, or by placental histology in terms of seeing actual parasites in the placenta. But as you can see, the actual rates of malaria infection were quite low by those metrics, sort of 3 to 4% in the blood samples, slightly higher in the placenta. We also didn't see any impact on anemia, although anemia is very common in this population. About 3/4 of the women were still anemic at delivery, despite our anti-malarials, despite bed nets, despite iron tablets, and no difference between the arms. So we don't really think that this amount of malaria in our control arm is really enough to explain all of what's going on. So if the effect is not explainable through anti-malarial activity, what might be causing the benefit? And over the next few minutes, I'll kind of raise a few different possible scenarios. So the first of these was sexually transmitted infections. And as Fiona pointed out, these are really quite prevalent in communities like this. So this was qPCR done before administering any drugs on self-collected high vaginal swabs. And what you can see is that there was a high prevalence of trichomonas, but also most notably of chlamydia and gonorrhea, both of which should be amenable to treatment with azithromycin. Unfortunately, we did do a swab at the second treatment visit, but there were problems with that data, and we didn't get follow-up data to really try and monitor the impact on carriage. We also didn't have the budget to kind of look properly for chorioamnionitis in this population, which could also be a possible explanation. So that's one thing, STI high prevalence, which might be mediating the effect. As we've heard a couple of times around, there's issues around azithromycin and carriage of bacteria, but also around resistance to bacteria. And in 859 of our participants, we collected from the mothers at delivery a nasopharyngeal swab and cultured it for Strep pneumoniae, Haemophilus influenzae, and Staph aureus. And what you can see here is that although there was no impact on Staph aureus carriage, the carriage rates for Strep pneumoniae were decreased by about 2/3, and for Haemophilus influenzae by about 50%. Moreover, we did resistance typing on those organisms of the Strep pneumoniae, and in the chloroquine arm, although we had a high number of isolates, only 2 of them showed azithromycin resistance, whereas amongst a smaller number of isolates in the azithromycin arm, 4 of those were resistant, and there was no effect on penicillin resistance. So to summarise nasopharyngeal carriage, we saw a decrease in the rates of carriage of strep pneumoniae and Haemophilus influenzae, but not Staph aureus. But of the carried pneumococci, more appeared to be resistant to azithromycin. So I think, you know, it's obviously something that, as Fiona's pointed out, does need to be monitored in future studies. One of the other things we were interested in was inflammation as a possible marker of predisposition to poor pregnancy outcomes. And we looked at a number of angiogenic markers, but also at acute phase proteins, C-reactive protein, CRP, and alpha-1 acid-glycoprotein, AGP, by ELISA at our enrolment sample. So this was before women had started on treatment. And then we looked at the pregnancy outcome. We categorised our acute phase protein markers into either elevated plus or normal range minus. And what you can see firstly in the left-hand panel of this figure is that overall, if you are in the 2 clear shapes, that the birth weights, that is amongst women who had elevated AGP, were about 100 grams lower than they were for the women who didn't have elevated AGP. Whereas if you look at CRP minus versus plus, there's no real difference in birth weight. If we then divide it according to the 2 different treatment arms, we can see that that effect seems to be limited to the SP chloroquine arm. So that the mean birth weights amongst those with elevated AGP were about 200 grams lower than those who had no elevation in AGP in the SP chloroquine arm, whereas in the SP azithromycin arm, there's a pretty consistent pattern of birth weight distribution across our 4 different groups. So inflammation, SP and azithromycin seems to be affecting something that is manifesting as inflammation at first presentation, although we can't say exactly what it is. The final component I want to look at is nutrition. And in this part of the world, there's a very high prevalence of stunting. About 40% of our mothers had a height of 150 centimetres or less, and 28% had a low mid-upper arm circumference, another marker of poor nutrition. Smaller percentage had low body mass index adjusted for phase of pregnancy. And then gestational weight gain is supposed to be around 350 to 500 grams per week. That's the recommendation of the Institute of Medicine. We divided our population into the lowest quartile and the remaining 3/4 at around 226 grams per week. So you can see that's a low weight gain. And you can see in the table below that the birth weight was significantly lower in those who had poor gestational weight gain, and the low birth weight rate was significantly higher in that group. There was also a trend towards being a high number of preterm deliveries. Now, we only had part of our population in whom we could actually assess this, so perhaps if we'd had a bigger sample size, we'd also would have shown effect on preterm birth. But most importantly, for this talk, when we stratified our women by treatment arm and then looked at anthropometry in the mothers and in the infants, we can see that first the gestational weight gain was actually higher in the SP azithromycin group by 58 grams, and the postnatal body mass index in these mothers was also slightly higher than in the control arm. And of the babies who were seen at somewhat varying times, it was supposed to be 6 weeks, but it varied a bit. But in terms of being their weight for age and length for age, there was an effect on being underweight and wasted, although we didn't see an effect on stunting. So to summarise, the combination of SP and azithromycin given 3 times during pregnancy to pregnant women in New Guinea was associated with a reduction in low birth weight and an increase in mean birth weight and a reduction in preterm delivery. Although there was a reduction in malaria at delivery, we don't think that that really is enough to explain those benefits. It did decrease nasopharyngeal carriage of strep pneumoniae and Haemophilus influenzae, although there might have been some selecting out for macrolide resistant pneumococci. In this population, there's a lot of potentially azithromycin responsive STIs, which might help explain the benefit. And then there was an effect on there was an effect on inflammation, possibly due to anti-infective effects, although azithromycin is also an anti-inflammatory, and so it could be through decreasing excessive maternal inflammation of other causes. And then there were positive effects on maternal weight gain and anthropometry. So firstly, we're not sure if this is actually azithromycin or it's the SP or it's both. There's a bit of debate in the malaria and pregnancy community at the moment as to what off-target effects of SP might be occurring as well. And secondly, we don't really know how this is mediated. So is it an anti-infective effect? If so, what are the infections that are responding? Is it an anti-inflammatory effect? Could it be mediated through effects on the maternal microbiome? Because both of these drugs potentially can alter the microbiome in a way that could potentially lead to increased growth or increased, I guess, maternal weight gain. So I'd just like to acknowledge everybody that worked on this study, and thank you for your attention.
Thank you, Stephen. Fascinating to hear the results and also the questions that have arisen from the study. So thank you for sharing with that so clearly. So we've got 10 minutes now for questions. I'd like to introduce Josh Osowicki, who's a paediatric infectious disease physician at the hospital and researcher at MCRO in the university. And Josh and I are going to share the question asking. So Josh, do you want to go first?
So the first question, the only remaining question, in fact, on the Q&A is from Kim Mulholland for Steve Rogerson. Could chloroquine, in fact, be associated with a small incidence of premature labour?
I don't know of any data around that, Kim. And I think chloroquine's been looked at fairly closely in pregnancy in the past. It hasn't really been used much in the recent era. I don't think it's having a negative effect, if that's, I guess that's what you're suggesting. I don't think so. Certainly there's evidence that SP can have some positive effects that are not due to its anti-malarial activity on birth weight from some of the African studies carried out recently. So whether it's azithromycin that's causing our benefits or is it SP, I don't know.
Sure. And I suppose this is a question for everyone really, but are we discussing an emergency rescue intervention here or a health maintenance activity?
Who wants to go first on that tricky question?
I can, well, I guess.
Oh, sorry. You go straight.
I just think in pregnancy, we're obviously looking at trying to clear IPTP is designed to both treat and prevent malaria infection because there's pretty strong evidence for negative effects of malaria on pregnancy outcome. Now, whether these drugs are having off-target effects, I don't know, but I guess I would call this sort of, well, I suppose it's sort of a bit of at the interface between the two, health maintenance or health improvement. I don't know, Fiona.
Yeah, I think like most of these things, Josh, I think it's probably a bit of nuance and depends on the, the setting. Certainly, every other high-income country is trying to reduce antibiotics, and here we are, talking about mass treatment of antibiotics. So, I think the pros and benefits sort of depending on the context, depending on the mortality rates, depending on the AMR, depending on a whole range of factors, I think would need to be taken into account as to, how to make decisions on these things. It's not sort of just okay, Africa, you do this, and Asia, you do that, or whatever. It's sort of, there's a whole lot of things. And then, and again, depending on the setting as to whether you need to be more strategic and be a little bit more, like we're trying to do, I suppose, in Fiji, is we're trying to be a bit more strategic in who to target rather than just everybody gets something. But again, it depends on the logistics. It depends on access to care. Like somewhere in Niger, they probably don't get access to much care at all, I would imagine, you know, very challenging. And so something like mass treatments would potentially have enormous benefit, you know, when you know, children have very little access to care and antibiotics aren't available.
Thanks, Fiona. I might just extend a question from Nathan Grills, and I'll direct it first to John and then maybe to Fiona. And Fiona, I know that your clock behind you says 1:30, but I think we've got 5 minutes still to go. So the question's around adverse events. And so one of the concerning adverse events of macrolides in young children, in young babies, is pyloric stenosis. So I guess the first part of the question is to John around, was there a signal at all, and what sort of adverse event monitoring was done? And then to Fiona, you know, how you've approached that in your trial.
Yeah, thanks, Andrew. So that was a concern and something that we considered from the start of the trial. And we actually, so we started treating from 1 month and older, and by weight only those more than 3.8 kilos, because we know that risk of infantile hypertrophic pyloric stenosis is greatest in preterm infants, and particularly in the first couple of weeks. And we didn't have any evidence in Mordor. So the HSAs, so they're resident in their communities, they distribute the drug, and any adverse event goes through them and then was reported into the study coordinator. So we'd have heard of those events, and we don't believe there were any such cases through Mordor.
Yeah, so yeah, extremely important to monitor. So as John's Hart has outlined sort of in the studies he's been involved with, and similarly for our study in Fiji, we have every single event, you know, serious adverse events sort of monitored, and we do capture because we're individually randomizing our capturing. But we did look at the background rate and, you know, before setting all of this up, and pyloric stenosis seems to have a different rates by ethnicity. So using US data, there's higher rates of pyloric stenosis in the, well, lower rates of pyloric stenosis in Americans of African origin, and also Asian Americans as well. And so when we took that into account with looking at what we would expect, you know, based on you know, the rates, and also what's the background rate in Fiji, I mean, it's extremely unlikely in the course of our trial that we'd get a single case, and there's certainly treatment available if that were to occur, but certainly we're monitoring it. Yeah.
Thanks. Josh.
I was muted.
Josh, you're on mute.
Of course I am. A question from Kim that came up a little bit earlier. So the Niger effect in Mordor is where the effect was seen. Malaria is highly seasonal in Niger, but the CID paper shows that the mortality reduction was minimal during malaria season. There's a recent study from Mali and Burkina Faso that shows the addition of azithromycin to SMP makes no difference to mortality, seeming to refute those Niger findings. The other difference is Niger is high 1 to 5 mortality. Could the whole effect be mediated by impact on pneumococcal disease?
Well, I think it certainly could. We don't know what the mechanism of effect is. So that study from Mali and Burkina Faso, Daniel Chandramohan and Brian Greenwood, it wasn't powered to detect a mortality difference, but it did show that in that setting where they were getting 3 rounds of seasonal malaria chemo prevention, there was no additional mortality benefit from adding azithromycin to that SMC, but it was a low number of deaths. I think there were about 60 deaths or something in each arm, and it did show reductions in morbidity and hospitalization with azithromycin. So I don't think there's strong evidence there that in a setting of SMC, that the azithromycin MDA can't have a mortality benefit. But I think that's the nuances we're talking about and that Fiona was mentioning. Where should this be implemented? Is it a stopgap measure? Is it a sticking plaster? And for how long? It's probably needed where there is higher mortality. When there's higher mortality, we know more of that is infectious. But the breakdown of that, whether it's in particularly high malaria areas where this is going to have the greatest benefit, we don't have the data to fully answer that question yet.
Thanks. I think that's a great place to leave it. There's obviously room for much more discussion and many more questions, and I encourage you to follow up with the speakers individually with further questions. I've had some really good discussion going on in the Q&A and the chat, and so please join me in thanking, like this I guess, our three speakers for outstanding presentations today and really great discussion. And thanks to the organisers again, Josh Osawicki, Anna Doe, Nicole Romero, Ricardo Atade, and Layla Larson. And thanks to Stephen, Kanta and Kim for their support of all of this. And we look forward to seeing you for the next seminar, which will be in 3 months' time. Topic and date to be advised. But thanks again, and we'll see you soon.
Thank you.
Thank you.
Thank you very much.